Welcome to the Alliance for Clinical Trials in Oncology webinar on cancer research advances. My name is Eva Galanis. I'm a professor of oncology at the Mayo Clinic, and it is a true privilege to welcome you all today in my role as the chair of Alliance for Clinical Trials in Oncology. For some of the participants who may not be so familiar with the group, Alliance is a national cancer clinical trials network. We are funded by the National Cancer Institute, and we're very grateful for this support and partnership over the years. We unite more than 25,000 cancer specialists in more than 1,500 sites, both academic and community-based. Our goal is one and only: to improve outcomes for all cancer patients and end cancer as we know it. To do that, we focus on moving scientific advances to the clinical forefront and testing them in well-designed trials. For example, just in the last 6 years, we have treated more than 15,500 patients in clinical trials we developed, and many of those studies have changed the standard of care, changed national guidelines, and led to FDA approvals. So we're really excited to welcome you all today so we can share some of these latest advances. So now, without further ado, I would like to welcome Dr. Owen Han. Dr. Han is an associate professor of medicine at the University of Chicago, and she's a vice president of Alliance Foundation, and she will be moderating the session. Owen, welcome.
Thank you, Dr. Galanis. It is my privilege to moderate the Best of Alliance at ASCO, and I want to thank in advance our esteemed panelists who are presenting their research on behalf of Alliance. It was very challenging to present the 5 abstracts that you'll be hearing today that represents the work that Alliance presented at ASCO in June in 2025. Our first speaker is Dr. Tian Zhang, who is an associate professor and director of clinical research at University of Texas Southwestern Medical Center. She's going to be presenting Alliance 031704 PDIGREE, Ipilimumab and nivolumab in patients with metastatic clear cell renal cell carcinoma treated on the phase III PDIGREE trial. These are the results from the step 1 analysis. Dr. Zhang.
Hi, everyone. Thank you so much for the Alliance team having me present about PDIGREE and do a reprise of the data that we presented at ASCO this year. Truly a privilege to be showing everybody what we learned from our demographics of step 1 and also going into step 2 of the PDIGREE trial. Let's see if we can toggle. So key takeaways from the ASCO presentation are that immunotherapy doublets remain standard of care for patients with metastatic kidney cancer, clear cell type. Fewer patients with IMDC poor risk disease as well as bone metastases were treated in step 2 of PDIGREE and represents I think, a more vulnerable patient population that we may not use Ipi/Nivo in the frontline setting for. And PDIGREE may inform our immunotherapy sequencing and adaptation before radiographic progression in its adaptive design. Many of you who are on the call probably had PDIGREE open for your kidney cancer patients. So this is our rationale for PDIGREE. Our standard frontline therapeutic landscape for metastatic clear cell kidney cancer includes immunotherapy doublets, in particular Ipilimumab and nivolumab per CheckMate 214, as well as cabozantinib and nivolumab as per CheckMate 9ER. Both of these regimens have improved overall survival for metastatic kidney cancer, particularly those with IMDC intermediate and poor risk disease. And so PDIGREE was developed to evaluate sequential treatment of Ipi/Nivo followed by Cabo/Nivo versus nivolumab adapted to patients' 3-month radiographic responses. So we designed this trial way back in 2014, and it morphed, and I'll show you a timeline here shortly. But this is the schema of the PDIGREE trial. It enrolled patients with metastatic clear cell renal cell carcinoma with no prior systemic treatments, and IMDC intermediate and poor risk disease. Step 1 induction treatment was ipilimumab and nivolumab every 3 weeks for up to 4 cycles. And then on the 3-month responses by radiographic responses, treatment was adapted for those CT findings. So patients who had complete responses received nivolumab alone, patients with progressive disease received cabozantinib alone, and everybody with partial response or stable disease were randomized to either nivolumab alone as per Checkmate 214 or nivolumab with cabozantinib in a sequentially adaptive design. Patients were discontinued from treatment for progressive disease, unacceptable toxicities, or complete responses at 1 or 2 years. And our primary endpoint was overall survival of the randomized cohort. We ultimately enrolled 1,111 patients across all NCTN centers and randomized 597, and I'll take you through the consort diagram here. So 1,111 patients were enrolled to step 1 between May of 2019 and May of 2024. Our data cutoff for the step 1 analysis that we presented at ASCO this year was in January of this year. Of all of the patients who enrolled to step 1, 67% of those enrolled into step 2. Of those, 597 were ultimately randomized, and 141 were treated on the progressive disease cohort, and 9 patients treated on the complete response cohort. Of those 364 patients who withdrew before step 2, 160 of those patients withdrew due to adverse events. 46 withdrew for progressive disease. Indeed, 5 even before they began step 1 therapy. And then 42 patients withdrew voluntarily, 39 for alternative therapies. And unfortunately, we did see about 37 deaths, including 15 from adverse events. Most of the others were due to complicating disease and disease progression. Of those step 1 and step 2 patient characteristics, here are the baseline patient characteristics by patient level factors. So here we're highlighting the intention to treat population, all 1,111 patients. You'll see median age 64, 74% were male, 10% were Hispanic, Latinx. And another, if you add Black, Asian, American Indian, another 8% or so were underrepresented minorities. And if we look at step 1 discontinued versus step 2 patient populations, really at the patient level, not much difference in the patient cohorts that went on to step 2 versus those who discontinued treatment in step 1. There's maybe nominally a few more men who discontinued, who were able to enroll to step 2 versus discontinued treatment in step 1. However, when we look at disease characteristics, this tells a different story of patients who discontinued versus those who enrolled into step 2. As you see, our intention to treat population, there was about 77% intermediate risk disease, 23% poor risk disease. 27% had bone metastases, and 54% had de novo metastatic disease. We also looked across the enrolling sites, and of note, 49% of patients were treated at community centers, community oncology centers across the NCORP network, which was really quite notable for the representative patient populations across the U.S. When we look at those who discontinued during step 1 versus those who were able to enroll to step 2, we did see fewer patients that with an IMDC poor risk disease that enrolled into step 2, so more who withdrew potentially for progressive disease during step 1, and then also fewer patients who had active bone metastases were able to enroll to step 2. We did not find differences for de novo metastatic disease or for those enrolling across the enrolling sites of treatment centers in the U.S. This is a summary of our grade 3/4 treatment-related toxicities. You'll note mostly immunotherapy-based complications like colitis, transaminitis, and rashes. Few adrenal insufficiencies and fatigue round out this list. There are 15 grade 5 events, deaths due to adverse events, and you'll see them listed there. First and foremost, so that was the entirety of the data that we've presented at ASCO. Our primary endpoint is certainly still ongoing for the overall survival events, but I do want to take an opportunity to thank each and every one of our more than 1,100 patients who enrolled to PDIGREE and all of the participating sites and more than 500 centers who had PDIGREE open over the last 5 years. Wanted to give you a taste of the timeline for PDIGREE. Our initial conversations about concept design was in 2014. Renal Task Force reviewed this trial in 2018, and then GU steering approved the study in December of 2018. PDIGREE opened formally in May of 2019, and over the course of the 5 years, we had a steady enrollment. Although the first 6 months our enrollment did lag, we started in physician newsletters, investigator meetings, and also amplifying the trial and patient advocacy groups. One of our colleagues, Helen Moon, wrote PDIGREE into the clinical pathways of Kaiser Permanente in Southern California, and they ultimately treated more than 60 patients on PDIGREE over the course of the lifetime of PDIGREE. We went through a pandemic, and we did have some early progression events in which we added iRECIST criteria to allow patients with unconfirmed progressive disease with clinical stability onto the randomized portions. We allowed radiation on trial to non-targets, and we further organized more investigator meetings to respond to investigator needs. We had a planned toxicity hold from the protocol, and we subsequently installed quarterly safety meetings with Alliance and the NCI. And then finally, late in the course of enrollment, we realized our randomization rate was slower than predicted, and so we worked with our biostatisticians to redesign the study with a lower randomized sample size. And this is an important note that Alliance trials, particularly PDIGREE, do span multiple years. And over the last decade that we've been thinking about PDIGREE, there were 7 industry phase 3 trials, which have truly changed the landscape of kidney cancer that you see there. And despite these phase 3s, we did have slow and steady enrollment over the last 5 years that it was open. It was certainly a lucky but also smart trial design that held its relevance even with the landscape changes. And it is also a story of career development. I was a fellow when we first started the concept discussions, and over the course of time, I was very fortunate to work with Dan George and Tony Schwery to really implement PDIGREE and take on leadership roles in my current institution at UT Southwestern, but continue our work and dedication to PDIGREE. So NCTN trials take a long time. Understanding where a field is going helps, but being lucky does help too. And our questions really need to be built on patient-centric issues. We do need to communicate steadily and often with investigator meetings and newsletters. And we need to listen and work with all of our investigators for protocol amendments, medical monitoring. I still get day-to-day emails about PDIGREE. And the kidney cancer community and patient advocates have been truly very supportive. And just like raising a child, a phase 3 trial like this in the Alliance group, the days are long, but the years are short. And we are still awaiting the primary endpoint, but the longer we wait, the better for our patient population. And so here you're seeing all of the sites that enrolled to PDIGREE, more than 500 sites across 46 states and also the District of Columbia. And we had more than 450 investigators who treated at least one patient on PDIGREE. The ones in green have treated more than than 20 in their practices. We certainly appreciate the work of the Alliance team, bolded in red on the right, who have worked tirelessly on pedigree over the last 10 years. And with that, I will open for questions.
Thank you very much. I would encourage anyone with questions, please put them in the Q&A box. And I will start off with some questions, Dr. Zhang. So, many kudos to you and your study team for all the hard work in launching pedigree, especially during the pandemic, and your commitment with working with the academic and the community sites. I think it's the success of the enrollment of pedigree is especially notable given the competitive landscape with all the pharmaceutical studies that you mentioned. Maybe could you comment on what is the role of NCI-sponsored cooperative groups such as the Alliance and our other colleagues in moving the field forward in renal cancer through studies such as pedigree?
Yeah, it's a great question, and one that we think about a lot now within the GU Alliance Committee. What are the meaningful trials that will answer questions that the industry doesn't answer? So, for example, treatment discontinuation. There's a number of trials ongoing in the cooperative groups asking questions around multidisciplinary care like surgery or radiation. And so I think those still have particular relevance, and we continue to enroll to those studies. But asking questions that are interesting and are patient-centric that our industry colleagues are not necessarily ramped up to do. Of a novel drug, for example, they're going to be much more equipped on the industry side to get to a registrational trial for a novel drug than we will be in the cooperative groups. But I think by asking good questions and questions of relevance to our patient populations, especially as they pertain to multidisciplinary treatments or potential sequencing of study of our active drugs, or even discontinuation. It's been hard to enroll to some of the discontinuation studies, but I think they're still relevant for our patients who may achieve really excellent responses and not want to receive lifetime treatment.
Sounds good. And the other thing I noticed is that the engagement in the community sites is very notable, nearly 48%. And can you discuss how you and your study team were able to achieve such a high enrollment of the community sites? You mentioned the kind of putting in the pathways for the Kaiser sites, but how else did you achieve such a high percentage of community site participation, especially in first-line renal cell cancer?
Yeah, that's a great question. So about half of our patients came from NCORP sites. To be honest, I think we just broadcasted pedigree quite a bit when it was initially launching. We worked with the Community Oncology Committee within Alliance, and then really discuss its relevance across all the platforms that we had available. So Kidney Cancer Association, for example, or the Kidney Can meetings. And ultimately, our colleagues also really gave a lot of endorsements. So quite a few of the discussions during all of the phase 3s as they were reading out, the industry phase 3s included pedigree as a sort of what's up and coming. And so I think all of those helped. I don't know that I did any particular community oncology engagements, but I'm certainly, those are important centers. And as they see relevance of the trial, I think they're also motivated to open. So having those players engaged early on will be helpful as our concepts go forward. I did see a question about when we would expect primary results from pedigree. So our Alliance statisticians have really kept the event number under wraps. We have gone through an interim analysis and we were not shut down for futility. So my best guess is sometime, 2026. I hope not further than that, but again, for overall survival, event-driven analysis, the longer we wait, the better for our patients.
All right. Well, excellent. Well, thank you, Dr. Zhang. So I think we're going to turn to our second presentation. And I would like to encourage all the participants, please feel free during the presentations to put any questions you may have in the Q&A box, and I will turn to them during the moderated Q&A session. But our second presentation is going to be by Dr. Sara Char, who is a clinical oncology fellow at the Dana-Farber Cancer Institute. And here she is going to present the findings from CALGB and SWOG 80702, the association between empirical dietary inflammatory pattern and survival in patients with stage 3 colon cancer. Dr. Char, please.
Thank you so much, and thank you to the organizers for inviting me today. I'm excited to talk about our study, which is looking at dietary inflammation and survival in CALGB SWOG 80702. Oops. So for the key takeaway points of our study showed that greater intake of a pro-inflammatory diet pattern was associated with worse overall survival in patients with stage 3 colon cancer. And this association was not affected by either low-dose aspirin use or daily celecoxib use. And in our cohort, the patients who engaged in the highest levels of physical activity and consumed a less inflammatory diet had the best overall survival. For some background that informed this study, we know that systemic inflammation is implicated in both colon cancer development and in its progression. In observational studies, elevated levels of plasma inflammatory markers, CRP, IL-6, and TNF-alpha receptor 2 after surgery is associated with worse survival outcomes in patients with stage 3 colon cancer. This year, we saw the presentation and publication of the ALASCA trial, which showed that low-dose daily aspirin, which is an anti-inflammatory medication, can reduce recurrence rates of stage 2 and 3 colon cancer in a specific population that have PI3 kinase pathway alterations. And as we also saw this year, physical activity, which is also associated with inflammation and its modulation, is associated with improved disease-free survival and overall survival, with the presentation of the challenge trial, which showed that a structured exercise program can improve both disease-free survival and cancer-specific mortality in patients with stage 3 colon cancer. Now, certain dietary patterns can also be correlated with systemic inflammation, and the empirical dietary inflammatory pattern, or EDIP, is a dietary pattern that was derived and validated in several large cohorts. It statistically correlates the intake of specific foods with plasma CRP, IL-6, and TNF-alpha receptor 2, which are inflammatory biomarkers. And by applying EDIP to patient-reported dietary data, we are able to get an estimate of how inflammatory a patient's diet can be. The EDIP score itself is a weighted average of 18 food groups, 9 pro-inflammatory food groups, and 9 anti-inflammatory food groups, which are shown here, with some pro-inflammatory food groups including things like red meat, processed meats, refined grains, sugar-sweetened beverages. And some examples of the anti-inflammatory foods would be leafy green vegetables, dark yellow vegetables, coffee, and tea. And together, the frequency and the quantity of intake of these 18 food groups can be added together to get a score, where a higher EDIP score corresponds with a more inflammatory diet and correlates with higher plasma inflammatory markers. Now, intake of a pro-inflammatory diet, as measured by EDIP, has been associated with a greater risk of colorectal cancer development in the Nurses' Health Study and the Health Professionals Follow-Up Study, which were both large cohorts. And similarly, intake of a pro-inflammatory diet is also associated with increased risk of developing breast cancer, endometrial cancer, and cardiovascular disease. So we specifically wanted to know, after a diagnosis of stage 3 colon cancer, does intake of a pro-inflammatory diet affect survival? To answer this question, we conducted a secondary analysis of the CALGB 80702 clinical trial, which randomized patients with resected stage 3 colon cancer in a 2x2 factorial design to receive either 3 versus 6 months of adjuvant FOLFOX chemotherapy, as well as celecoxib versus placebo daily for 3 years. Importantly, this was a negative study, and there was no significant difference in disease-free survival or overall survival with celecoxib use, which allows us to pool this cohort for our secondary analysis. In the clinical trial, low-dose aspirin use at less than or equal to 100 milligrams per day was permitted, but any baseline NSAID use was not permitted. A subset of the patients in this clinical trial had consented to a diet and lifestyle companion study where they completed questionnaires at 2 time points, 6 weeks after randomization and 14 to 16 months after randomization, which roughly corresponds to right before starting chemotherapy and after the completion of chemotherapy. As part of these questionnaires, they were validated food frequency questionnaires where participants detailed their dietary intake over the prior 3 months. Of the patients in the diet and lifestyle companion study, we excluded those who withdrew from the study or were lost to follow-up, had cancer recurrence or death within 60 days of completing the first questionnaire, or had responses that were either incomplete or implausible. And that left us with a final study cohort of 1,625 patients. This was a prospective cohort study where we examined EDIP and a primary outcome of disease-free survival and a secondary outcome of overall survival. We used a Cox proportional hazards model to examine this association. And for our primary statistical testing, we modeled EDIP as a continuous variable, but for ease of clinical interpretation, we also modeled EDIP in quintiles. And in our multivariable adjusted model, we adjusted for patient factors, tumor factors, as well as the assigned chemotherapy arm and pharmacotherapy arm they had been assigned to. The baseline characteristics of our study cohort resembled that of the clinical trial cohort. And when we look at our study cohort by EDIP quintile, where the highest quintile, Q5, represents the most pro-inflammatory diet, we see that the patients in the highest quintile were on average younger, more likely to be female, more likely to be Black, and had worse performance status. Importantly, when we look at baseline aspirin use as well as the chemotherapy arm and pharmacotherapy arm, this was not statistically significantly different across these EDIP quintiles. For our primary outcome of disease-free survival, when looking at those in the highest quintile, which is the most inflammatory diet shown in red, and those in the lowest quintile with the least inflammatory diet in blue, we see that there is a trend towards worse disease-free survival in those with intake of a more pro-inflammatory diet. However, this was not statistically significant in our multivariable adjusted model, and the P for trend is shown here. For overall survival, however, we saw that the median overall survival in quintile 5, which is the most inflammatory diet, was 7.7 years, but the median overall survival was not reached in quintile 1. When comparing quintile 5 to quintile 1, the multivariable adjusted hazard ratio was 1.87, and this was significant. So more inflammatory diet was associated with worse overall survival. When looking at overall survival across our subgroups, importantly, among the aspirin users and those assigned to receive celecoxib, there was no statistically significant difference. We then wanted to look at the joint interaction of physical activity and diet on overall survival. So for this analysis, we divided our cohort into 2 groups of physical activity, higher and lower activity, using a cutoff of 9 MET hours per week. And that roughly corresponds to about 30 minutes of vigorous walking 5 days a week and 30 minutes of light yoga. We also divided our cohort into higher and lower EDIP scores, comparing quintile 5, which was more inflammatory diet, to those in quintiles 1 through 4. And when we look at the Kaplan-Meier curve on the right, we see that the best survival was achieved in those who had higher levels of physical activity and lower EDIP scores, which is the line in blue. When compared to those who have lower physical activity and more inflammatory diet in red, the hazard ratio for overall survival was 0.37, and this was statistically significant. Some limitations of our study is that this was a post-hoc analysis, which included just a subset of the overall trial patients. The dietary data were collected using a validated tool, however, are self-reported and thus subject to recall bias. And EDIP is a validated inflammatory dietary pattern that's been associated with a number of different health outcomes, but it doesn't represent a dietary recommendation and can't be used as such. And we need future studies to be able to tailor these findings into a recommendation for patients. Dietary studies in general can be very challenging to design and conduct and very difficult to do in a randomized fashion. So the diet and lifestyle companion study built into this clinical trial really provided us with an invaluable opportunity to study diet and colon cancer outcomes. Our study findings show additional evidence that diet may be important for improving outcomes with stage 3 colon cancer. And we need future studies to be able to understand the biological mechanisms that might be underlying a relationship between a pro-inflammatory diet and survival. And as part of this, we plan to conduct a sensitivity analysis with plasma inflammatory biomarkers to see what the correlation is among the EDIP quintiles in our cohort. So in conclusion, greater intake of a pro-inflammatory diet pattern was associated with worse overall survival, but not disease-free survival in patients with stage 3 colon cancer in our study. Daily celecoxib use and low-dose aspirin use didn't impact this association. And we found that the best survival was achieved by those who had higher levels of physical activity and consumed less inflammatory diets. I'd like to acknowledge the patients who participated in this trial and also took the additional time to complete these really detailed and comprehensive diet and lifestyle questionnaires, as well as the Alliance for Clinical Trials in Oncology and the NCTN, as well as our sources of funding from the NCI and the Project P Fund. And we're happy to take questions. Thank you.
All right. Thank you, Dr. Char. And please put any questions in the Q&A box. So I know you mentioned that this does not result in a dietary recommendation, but I think as a result of your presentation, as well as a subsequent challenge presentation that occurred at ASCO, patients and oncologists, that are now diagnosed with colon cancer, what can you advise medical oncologists who are treating colon cancer patients to kind of recommend for their patients regarding diet and exercise who are undergoing treatment?
I think, on an exercise standpoint, that's pretty easy. I think we have really convincing data, both observational and now randomized data, that exercise is beneficial and is specifically beneficial for cancer-related outcomes. So I think that that's a real no-brainer, and it's going to be a matter of how we implement these structured exercise programs in our health systems to be able to deliver this type of care. I think from a diet standpoint, it gets much more complicated. The EDIP score, as I said, is not a dietary recommendation, but I think some of the things that are promising is that a lot of the foods that fall in the pro-inflammatory group, like processed meats, red meats, refined grains, are things that also fall into the Western dietary pattern that we sort of know from other studies are associated with worse outcomes in general. And the American Cancer Society has dietary recommendations that recommend moderation or limitation of those foods and encourage increasing fruits and vegetable intake. And so that does provide a lot of support for also the foods that fall into our EDIP food groups.
So Dr. Sinnerkrove has a question of why do you think that aspirin or celecoxib did not attenuate the inflammatory effect of the diet?
That's a great question. I'm not entirely sure. It could be a dose-related effect where it's simply you needed more aspirin in order to be able to create the anti-inflammatory effect. It could be that there's something happening more at the gut level rather than the systemic level. It could be that inflammation is not what is underlying this association. And we really need to look at the plasma inflammatory markers to get a better sense.
And a follow-up question from Dr. Crawford. Were the inflammatory biomarkers measured at any point in the study? And you mentioned that there's going to be some follow-up studies regarding that. Can you provide any further detail?
So the blood samples were collected prior to the start of chemotherapy, so it would coincide with the first questionnaire. So it would hopefully capture a level of inflammation that corresponds with diet right between surgery and chemotherapy.
All right, well, thank you. Well, I think one of the notable things about this is, as you mentioned, it was a negative treatment study, but yet CALGB 80702 has provided 22 publications as well as presentations. So it's been a wealth of information for us to learn about the mechanisms of disease and has furthered our understanding. So thank you very much, Dr. Char. And I think we will turn to our third presentation. And I would like to introduce Dr. Frank Sinnerkrove, who is a professor of Mayo Clinic. I'm in Rochester, Minnesota. He is going to present Alliance A031704 Atomic, which is a randomized trial of standard chemotherapy alone or combined with atezolizumab as adjuvant therapy for patients with stage 3 deficient DNA mismatch repair.
Thank you very much. And I appreciate the opportunity to present the Atomic trial, which was presented in the ASCO plenary session this year. Can you advance the slide for me? Seem to be able to. So deficient mismatch repair pathway is the target population. These tumors show microsatellite instability. About 1/3 are due to Lynch syndrome. 2/3 are typically sporadic. They tend to be older patients, and there's epigenetic inactivation of MLH1 with frequent BRAF. These tumors are hypermutated. They have abundant neoantigens that are recognized as foreign, and they trigger an intratumoral, very robust immune response. The prevalence of DMMR in stage 3 colon cancer is in the range of 9 to 15%. And these tumors are generally thought to have a better prognosis, but we've seen that when they're N2, so if there are 4 or more metastatic regional lymph nodes or they're metastatic, they do not have an improved prognosis. In fact, it may be worse in the metastatic setting. Next slide. So in stage 3 colon cancer overall, we know that despite adjuvant chemotherapy, about 30% of patients will experience recurrence. And standard adjuvant therapy consists of fluoropyrimidine, fluoxetine, regardless of the mismatch repair status. DMMR tumors display resistance to fluoropyrimidines, but they may benefit from oxaliplatin. And immune checkpoint inhibitors we know is standard therapy for the metastatic DMMR tumors, but it was unknown if a PD-1 or PD-L1 inhibitor could improve outcomes after surgery for non-metastatic DMMR colon cancer. Next slide. So this is the study design of ATOMIC. It was a randomized, multi-center, open-label phase 3 study. Patients were eligible if they were at least 12 years of age. They had to have histologically confirmed an R0 resected stage 3 colon adenocarcinoma. They had to have deficient mismatch repair determined by immunohistochemistry. There was retrospective central confirmation of that status as part of the trial, and they could have not received any prior chemotherapy or radiation. However, we did allow 1 cycle of FOLFOX prior to randomization to give sufficient time for the MMR result to be available. Stratification factors are as shown. Patients were enrolled within or at 10 weeks of surgery, randomized 1-to-1 to modified FOLFOX6 plus atezolizumab given concurrently for 6 months, with the atezolizumab given as monotherapy for an additional 6 months. So total of 1 year of checkpoint inhibitor, and this was compared to modified FOLFOX6 alone for 6 months. The primary endpoint of the study was disease-free survival, with secondary endpoints of overall survival and adverse event profile. Next slide. So ATOMIC was designed in 2016 with 1 year of duration of atezolizumab being modeled on pivotal melanoma trials showing durable survival benefit with 1 year of checkpoint inhibition. And at the time the protocol was developed and the study began, 6 months of adjuvant FOLFOX was standard of care, as ATOMIC was designed before publications of the IDEA collaboration, which allowed a shorter duration of chemotherapy for clinical lower risk tumors. Next slide. The statistical features of the trial, the target hazard ratio was 0.6 with an estimated 3-year DFS of 84% for the combination versus 75% for FOLFOX alone. The study was powered as shown. The target accrual was 700 patients, and we did 2 interim analyses at 50 and 75% of events, with 665 events being required at the final analysis. We assessed efficacy in all randomized patients on an intent to treat principle, and we assessed safety in any patient that got at least 1 dose of study treatment. Next slide. We enrolled 684 patients at NCTN sites and 28 from the German AIO cooperative group, and we completed accrual in January 2023. We randomized 712 patients, and at the second interim analysis of 75% of events, the DFS crossed the pre-specified boundary for efficacy, and the data were then released with a median follow-up this time is 40.9 months. Next slide. This is the consort diagram. One can see the 2 study arms. And in terms of completion of treatment per protocol, in the atezolizumab containing arm, 46% versus 60% for FOLFOX alone. And early discontinuation of treatment, 54% in the combination, 40% in FOLFOX monotherapy. And we can see adverse events being more common in the combination arm and withdrawal during treatment being more common also. And we'll talk about the safety in a subsequent slides. Next slide. Baseline characteristics were very well balanced between the study arms. I'll point out that the numbers of T4 tumors and the number of N2 tumors were virtually equal between the study arms. So very well balanced in terms of risk, in terms for the study population, age, and other factors as well. Most all of the tumors, 84% were, 83 to 84% were in the proximal colon. Next slide. One looks at the treatment exposure by study arm, we can see that in terms of looking at overall duration of FOLFOX, roughly equivalent by study arm, and when he breaks it down into bolus 5-FU, infusional 5-FU, or oxaliplatin, they're very similar. So the addition of atezolizumab did not significantly compromise the chemotherapy that the patients were able to receive. Next slide. This is the primary endpoint of disease-free survival. One can see that the combination arm with atezolizumab, 86.4% 3-year DFS versus 76.2% for FOLFOX alone. The divergence of the survival curves occurs very early, and there's plateauing of the combination arm, suggesting that we are likely curing some of these patients. The hazard ratio 0.51, indicating 49% reduction in recurrence or death, highly significant p-value. Next slide. And this is with the central confirmation of DMR status at an outside reference laboratory. We see very similar survival curves and hazard ratio for this. Next slide. And this is the forest plot showing the DFS by subgroups. And we can see that the benefit for FOLFOX plus atezolizumab is seen across all subgroups examined. And you can see everything is less than hazard ratio of 1, with the hazard ratio shown off to the right. So we're basically benefiting all subgroups with the addition of atezolizumab to FOLFOX. Next slide. Our overall survival data are not mature. As of this writing, we're about 45.8 months. And you can see we only have 31 overall survival events in combination arm and 33 in FOLFOX. And at this time, the hazard ratio is not significant. But the overall survival comparison, we know eventually when we have such the mature data, will likely be confounded by subsequent immunotherapy, which will be administered to patients at the time of recurrence or metastasis. Next slide. Oops. So looking at the safety summary for the patients, unfortunately, some of the slides got a little bit distorted, but if we look at grade 3 and 4, hematologic and non-hematologic, we can see that for hematologic toxicities in the grade 3 and 4 for the combination arm, 69.1 versus 54.2, and for non-hematologic, 46.8 versus 38.6. So higher rates of grade 3 and 4 toxicity in the combination arm, and this is all adverse effects, not just treatment related. Next slide. And the darker colors here actually are grade 3 and 4. We can see that there's an increase in fatigue in the combination arm, grade 3 and 4, 10% versus 4. And also there's an increase in patients who experience neutrophil count decrease, 44% versus 36%. This was non-febrile neutropenia. And these two side effects are the ones that are the most noteworthy for the combination of drugs for all side effects examined. This plot here currently shows patients with experiencing 10% or more side effects. Next slide. And this is for the suspected here we go. Suspected immune-related side effects. In grade 1 and grade 2, we can see that for the atezolizumab containing arm, there is more Hyperglycemia, hypothyroidism. Hypothyroidism is 19.9% versus 3.6% in FOLFOX alone. But when we get to grade 3 and 4, we don't really see any clinically significant increases in grade 3 or 4 immune-related adverse events, at least which we suspected to be immune-related. So overall, not much in the way of increased suspected immune toxicities at the grade 3 and 4 level. Next slide. So in conclusion, for ATOMIC, modified FOLFOX6 plus atezolizumab demonstrated a statistically significant and clinically meaningful nearly 50% reduction in recurrence or death over FOLFOX alone. The safety was in line with the no safety profiles of each, with a manageable increase in non-febrile neutropenia. And atezolizumab plus FOLFOX is a practice-changing, and we regard it as a new standard treatment for patients with dMMR stage 3 colon cancer. Next slide. And ATOMIC data has now been incorporated into the most recent version of the NCCN guidelines. And interestingly, the NCCN felt that the regimen could be recommended in the higher risk stage 2, the T4B population, which we know has a prognosis that is similar or in some cases worse than the low risk stage 3 population. And also they approved for the addition with CAPOX, not just FOLFOX, as studied in the ATOMIC trial. And we'd like to acknowledge the participants in the ATOMIC trial for the Alliance Cooperative Group, the NCTN, the German AIO, and all of our co-chairs and collaborators on this important study and getting it completed in this small molecular subgroup. So I thank you very much and happy to take questions.
All right. Thank you, Dr. Sinnerkrop, and congratulations to you and your study team, and well done study, the plenary presentation, and most importantly, have a practice-changing study that's been incorporated in NCCN guidelines and now readily available to our patients. I think one question I have is, I know with ATOMIC study, there has been a lot of sub-studies in correlative science built into ATOMIC. Can you give the audience a little bit of a preview about what we can expect moving forward in terms of some of the sub-studies in the correlative science that will be coming out of ATOMIC that we can learn about moving forward, in addition to the maturing overall survival analysis?
Yeah, sure. No, thank you. One of the things we're very interested in is looking at the circulating tumor DNA in ATOMIC, because we want to see if clearance of the circulating tumor DNA correlates with the efficacy that we are seeing. And we do have serial plasma analysis in the population, so we can follow over time to look at that particular parameter. We're doing both whole exome sequencing and RNA-seq to try to identify, better explore the heterogeneity of the MSI population and try to understand what predictive biomarkers we may be able to identify for atezolizumab. There's also stool been collected for the gut microbiome, and we're very interested in looking and see if we can identify particular bacterial species that may be associated with response to the drug. So very extensive correlative science component with a lot of serum immune biomarkers that I did not mention in any detail.
Gotcha. Excellent. Any tips for the success of how you were and your study team able to successfully accrue in a timely manner to such a small subset of stage 3 colon cancer patients?
Yeah, no, great question. I think we were fortunate that there was a lot of excitement over the data that's been generated in metastatic disease. And we have, this universal immunohistochemistry for mismatch repair protein expression certainly helps people identify these patients. But we were we had a newsletter that we were sending to all of the sites to give updates on the study, and with a lot of communication among myself and various the co-chairs from the different from the Alliance, but also the other participating cooperative groups to make sure that we were meeting our accrual objectives. It was a kind of a slow, continuous, steady accrual, about 11 patients per month, pretty much throughout the trial. We also endured COVID, but surprisingly, we didn't really slow slow our accrual down too much during the pandemic. So we had, gradual, slow, steady accrual throughout, and we're very fortunate for that.
Well, excellent. Well, thank you very much, and look forward to hearing the further updates about Atomic moving forward.
Thank you.
All right. Excellent. Well, I'm going to introduce our next speaker, Dr. Ellen Smith, who is Professor and Assistant Dean of Research and Scholarship at the University of Alabama. And she'll be presenting Alliance A021705, duloxetine to prevent oxaliplatin-induced chemotherapy, peripheral neuropathy, a randomized double-blind placebo-controlled phase 2 study. Dr. Smith.
Thank you. Thank you for the invitation and the opportunity to present our results today. And so I have control of the slides, but I'm trying to see how that works. I guess, here we go. So first, some background about neuropathy, and I'm sure most of everyone attending today already know a lot about this. We know that neuropathy is caused by certain types of neurotoxic drugs. We know that the most common side effects are sensory in nature, numbness, tingling, and in a smaller subset, neuropathic pain. We know that neuropathy is a problem because it can persist for months to years after the completion of chemotherapy, and we care about that because it is associated with numerous adverse outcomes, such as impaired function and quality of life, increased healthcare costs, and of course, most importantly, it is one of the main reasons why we often have to reduce the dose or change chemotherapy plans to try to mitigate severe neuropathy. So this study builds upon our prior study that was conducted through the CALGB, where we found that duloxetine can mitigate painful neuropathy, so neuropathy that's already developed. But again, to date, although there are many promising treatments on the verge, there's still nothing that we know that we can use to prevent the problem. And so, again, this was a phase 2 study, and the primary objective was to try to identify a more promising dose of duloxetine to potentially prevent sensory oxaliplatin-induced neuropathy. And then if we were to find a more promising dose, then that would be moved on to a fully powered phase 3. The secondary objective was to characterize the toxicity of duloxetine. Here's our schema. So you can see in the phase 2 component, we randomized patients to receive either 30 milligrams or 60 milligrams daily. And again, the plan was if we were to find a more promising dose, then we would move that forward into a fully powered phase 3. The main eligibility criteria for this study, and there are many, but these are just the two big ones. Patients had to have either stage 2 to 3 colorectal cancer and be receiving oxaliplatin via one of these 3 regimens, so the typical 3-month CAPOX or 3 or 6-month FOLFOX regimens. Our primary outcome was assessed after patients had received the same cumulative oxaliplatin dose, regardless of the treating regimen. So this fell somewhere between week 19 and week 21. And we measured that primary outcome using a validated patient-reported outcome measure that focused again on numbness, tingling, and pain. We designed our response target by looking at data from a previous study led by Charles Laprinzi and colleagues, where they tested calcium and magnesium in a similar population, in a colorectal cancer population, also to prevent neuropathy. They also used the CIPN20. And what you see here is a pie graph that's a bit distorted, but the main issue here is these are data from that study that suggested that when you look at the proportion of patients who reported either no neuropathy at all versus very much neuropathy, In their study, 52% of patients didn't develop much neuropathy, and that's, to be expected. And what we wanted to do was to build upon that or improve upon that by increasing the proportion of patients that didn't develop neuropathy at all. The other important point here is that on the flip side, 48% of patients did develop quite a bit of neuropathy. And again, we're measuring neuropathy here via a patient-reported outcome measure and not the CTCAE. So we're able to demonstrate that patients do develop neuropathy even soon after cycle 6. So our response was defined by patients reporting a highest score of less than or equal to 2 for numbness, tingling, or pain, meaning they really didn't develop the problem at all. And our target was to, again, build upon that 52% to 70% of patients that did not develop severe neuropathy. Here are our demographic results. So we enrolled 199 participants across 73 sites. We found no differences in demographic or clinical characteristics across the 3 groups. You'll see here that the mean age was 55 years. Most participants were white, male, and had received FOLFOX. So here is the slide that shows you our very disappointing results. So when compared to the 2 doses of duloxetine, we found that there was no difference by treatment group, and you'll see here that there was a very high placebo response rate of 68%. You'll also see that drug adherence was low, and a good adherence was defined as patients taking at least 75% of this prescribed study drug. And so based on these results, we had to abort the phase 3 trial because even when controlling for low adherence, we could not show that duloxetine was better than placebo. Regarding our secondary objective to evaluate toxicity, here you can see the proportions of patients that reported the most common adverse events based on reporting at least a grade 1, and these AEs being at least possibly related to study drugs. So here you'll see that nausea was the most common adverse event. So what were the main limitations of our study? Really, this high placebo response is something that we've been thinking a lot about. We know through anecdotal evidence that both clinic staff and patients in many cases had high expectations that the drug would work based on our positive prior duloxetine trial. And we also know that placebo responses are higher when there really is nothing else out there that can be effective. We also know that using a patient-reported outcome measure likely influenced our high placebo response rate, in that pros are subjective measures and are more likely to result in placebo response or response bias. Another main limitation on, again, the sort of opposite side of using just a pro, we did not use objective measures, and we did not use them mainly because of the difficulty and cost associated with doing objective measures across multiple sites. And then the other thing that we've thought about a lot, at the time when this study was funded, there was no serum biomarker that could have potentially been a promising objective measure that we could have included as an outcome measure. Now there is significant emerging evidence to suggest that neurofilament light chain would be a potential objective biomarker that could be used across multiple sites. And so this is something I think that we should consider for the future. So the main takeaways, duloxetine is not more promising than placebo to prevent oxaliplatin-induced neuropathy. Our results were not confounded by low drug adherence, but perhaps high placebo response may have confounded our findings. And so we need to continue to do more neuropathy intervention studies, but I think we can learn about study design for the future. Of course, we should continue to use patient-reported outcome measures but we should also be thinking carefully about how we might in the future begin to use more objective biomarkers in our studies. And lastly, we should be thinking about placebo response mitigation. And there are methods for doing so that some of our industry colleagues have developed. And so then, seem to be stuck. Here we go. And so the impact on patient care. We can't say that duloxetine is more effective than placebo to help patients with their symptoms and their activities of daily living and ability to dress and walk and maintain balance and all of those things. But perhaps we can learn more by thinking about our study design and thinking about maybe our results is not necessarily completely negative. So we had a 65% response rate overall, which is an improvement over what we saw in the Laprinzi trial, and 68% of the placebo group had a response. So, you know, perhaps we can say that maybe it worked to some degree because we had a lot of response bias. And, you know, as we've begun to think about placebo response and understand the underlying mechanisms of placebo response, there's some evidence to suggest that the mechanisms within the central nervous system may be similar to duloxetine. And so for the future, at least, you know, we should be thinking about placebo response mitigation and perhaps biomarkers for the future. So acknowledgements, there are many people to thank, certainly the NIH and NCI for our funding, all of the network clinicians and research staff and Alliance staff, our patient participants, and all of our co-investigators across sites.
All right. Thank you, Dr. Smith. All right, well, Dr. Sinnerkrove has a first question here. Do you think that later onset neuropathy in patients after 8 or 12 cycles of oxaliplatin may be different and perhaps could benefit?
Right, so of course we know that the incidence of neuropathy is higher in patients who receive more cycles, that's for sure. The thing that we think a lot about is that this particular study was designed to prevent people from developing it altogether, as opposed to focusing on trying to decrease the percentage of people that had a certain severity. But yes, that could have been a limitation of this study, that maybe if we had accrued patients that had received higher oxaliplatin doses, that maybe we would have had a better outcome.
Well, I think one thing that's notable is that it is just as important for us to present our negative results as we do our positive results. So I definitely thank you for your leadership in leading a well-designed randomized phase 2 study. My question is, how do you think Alliance and our other cooperative groups are positioned to maybe deploy some of this placebo mitigation responses in a future symptom intervention study?
Yes. I think we have a real opportunity to think about that. So, I mean, we don't have time to get into the details, but for example, Lilly Pharmaceuticals has developed and tested a placebo mitigation procedure that they actually sell. And again, they tested it and they use it in many of their trials, you know, testing antidepressants and other medications for psychiatric conditions where placebo response rates are very high. And when you get into the literature about this, high placebo response rates are a main reason why our studies fail. And so this mitigation approach isn't difficult, and I think we should be thinking about it.
Excellent. Well, thank you. Well, we're going to turn to our last speaker. And so I have the privilege of introducing now Dr. Dan Zandberg. He is an associate professor and director of head and neck and thyroid cancer at University of Pittsburgh Hillman Cancer Center. And he is going to present Alliance 091802, a phase 2 randomized trial of Ipilimumab plus cetuximab versus Ipilimumab alone in advanced cutaneous squamous cell carcinoma? Dr. Zandberg.
So thank you very much for this opportunity to present our trial. Next slide. So the background here is that progress has been made in advanced cutaneous squamous cell carcinoma with the approvals of cemiplimab and pembrolizumab in 2018 and 2019 with high response rates and durability, but there's still a need for continued improvement in outcomes for these patients. Next slide. When we first developed this trial in 2016, we were armed only with preclinical rationale for PD-1, PD-L1 blockade, and also for the combination of cetuximab plus PD-1, PD-L1 blockade, in that cetuximab is an IgG1 monoclonal antibody, and as such, it induces ADCC, which can lead to crosstalk between NK cells and dendritic cells, and development of adaptive immunity, specifically generating CD8 T cells targeted against EGFR. And so with this background, next slide, we developed our phase 2 randomized trial for patients with advanced cutaneous squamous cell carcinoma that were randomized to combination arm of avelumab plus cetuximab, avelumab being an anti-PD-L1 monoclonal antibody, where they received 12 cycles of combination, and then if no progression, went on to avelumab maintenance. And that was compared to avelumab monotherapy with a primary endpoint of progression-free survival. Secondary endpoints are shown there, including response rate, toxicity, and patients were randomized or stratified for randomization based on PD-L1 status, positive versus negative, and HIV positive versus negative. And importantly, patients that progressed on avelumab monotherapy, they could cross over to combination if they maintain their performance status at the treating investigator's discretion. Next slide. The main inclusion-exclusion criteria were biopsy-proven advanced cutaneous squame, which included distant metastatic disease or locally advanced disease, non-amenable to curative surgical resection. These patients could not have received prior anti-PD-1 or anti-PD-L1. They could not have received prior cetuximab for advanced disease, although we did allow it if they got it in curative intent, as long as it had been more than 6 months. We included ECOG performance status 0 to 2, measurable disease by RECIST. For HIV positive patients, they were included if criteria were met, as shown there: CD4 greater than 200, viral load greater than or less than 200. And we did exclude patients that were immunosuppressed, including organ transplant patients, had autoimmune disease, as well as and/or CLL from the trial. Next slide. So the statistical methods, as I mentioned, primary endpoint was progression-free survival. As we developed the trial, cemiplimab was first approved in 2018. We opened the trial in spring of 2019. And so we reacted to the efficacy and powered the arm based on what we would expect with cemiplimab. And as such, the trial was powered to detect a 75% improvement in median PFS from 12 to 21 months, requiring 37 PFS events. It was an alpha of 0.2 for 54 evaluable patients total that was needed. Secondary endpoints are shown there. Overall response rate was by RECIST 1.1. Progression-free survival 2 was defined as the time from the scan showing progression on the avelumab monotherapy arm to the next progression or death event after crossover treatment, and our Alliance stats and data management team managed and oversaw the trial. Next slide. What happened was that after 31 events were observed, there were only 7 more patients, 5 in combination arm and 2 in monotherapy, that could have an event. And these patients were progression-free when they completed the full length of their follow-up or began an alternative therapy. So at most, there could be 38 events. And so the statistical team decided independently it was highly unlikely that 6 out of 7 patients would experience events, and submitted an early unplanned analysis to the Alliance DSMB. As part of this analysis, they did multiple sensitivity analyses, including one that all 5 on the combination arm had an immediate event. And in all the scenarios, the hazard ratios were less than the pre-specified threshold of 0.758. And so the Alliance DSMB reviewed and recommended full release of the data. Next slide. So over a span of 4 years, starting in 2019, we enrolled 60 patients for 57 evaluable, 28 on avelumab, 29 on combination arm. There was no difference between baseline characteristics between the arms. Median age was 72. Majority of patients were ECOG performance 0 or 1. 75% were PD-L1 positive. As expected with these trials, majority are head and neck. The cutaneous squamous was in the head and neck site, 84%. About a little over half had metastatic disease, and they were pre-treated. 80% received prior treatment of some sort, with 54% receiving multimodality, and about a third trimodality in the curative intent setting with chemoradiation or surgery plus radiation itself. Next slide. So overall response rate, confirmed ORR, was 27.6% in combination versus 21% in the avelumab monotherapy arm. Duration of response was not reached in both arms. Next slide. And the primary endpoint was progression-free survival, and avelumab plus cetuximab significantly improved progression-free survival compared to avelumab monotherapy, with a median progression-free survival of 11.1 months compared to 3 months, and a 24-month PFS of 39.7% compared to 23.57%. Hazard ratio was 0.48 with a p-value of 0.018. Next slide. We did exploratory analysis by PD-L1 status and found that those that were PD-L1 positive enriched for those that did better in both arms. You can see by TPS greater than or equal to 1, the combination arm with a median PFS of 19.3 months, and the avelumab monotherapy arm 4.8. Next slide. Forest plot shown here for PFS subgroup analysis, and all subgroups favored the combination arm, including presence of distant disease, head and neck primary, as well as the PD-L1 negative patients. Next slide. This is our PFS2 data. That is patients that started on avelumab monotherapy, the control arm, progressed, and then crossed over to combination. And interestingly, the PFS2 was similar to that de novo with combination, with a PFS2 of 11.3 months, only 9 patients here, but PFS2 of 11.3 months. And importantly, when those patients were on avelumab monotherapy, their median PFS was 2.8 months. So it was a patient population that progressed fairly quickly, and then had a more durable second PFS with combination. Next slide. Overall survival was observed. It was not reached in the combination arm, and 35.8 months in monotherapy. Next slide. So toxicities are shown here. Really, as expected, combination had higher toxicities, including grade 3, 48% compared to 21.5%, compared to monotherapy. The toxicity seen in combination were those known, such as infusion reaction, and 20%, an acneiform rash, and 20% for the grade 3s. That's known with cetuximab, and shown there are the grade 1, 2 treatment-related AEs that were most common. There were no grade 5 treatment-related adverse events, 1 grade 4 in the avelumab monotherapy arm, which was glucose intolerance. Next slide. So the limitations here is that the sample size was only 57 patients, and the efficacy of the control arm was lower than expected. So that median PFS was 3 months. We had projected it to be 12 months. And so the impact of our trial, we acknowledged, is in prospectively demonstrating therapeutic potential of IgG1 monoclonal antibody cetuximab plus blockade of PD-1, PD-L1 pathway in a randomized design, showing the contribution of components, rather than to say that avelumab should be the immunotherapy choice with cetuximab. Next slide. So we're proud of this trial, and our key takeaways conclusions were that avelumab plus cetuximab significantly improved PFS compared to avelumab monotherapy in advanced cutaneous squamous. After progression on avelumab monotherapy, crossover treatment with combination led to a median second PFS of 11.3 months, which is impressive. Our trial is unique as a prospective randomized trial of systemic therapy in advanced cutaneous squamous, and as a direct comparison of IgG1 monoclonal antibody targeting EGFR plus PD-1, PD-L1 blockade versus that PD-1, PD-L1 blockade alone. And that's something that's very relevant to head and neck cancer, head and neck squam, where there are a number of phase 2/3s going on with novel EGFR targets plus Pembro versus Pembro alone. And we feel our data confirms or supports the development of a larger confirmatory study of combination cetuximab and standard of care anti-PD-1 in the frontline setting for advanced cutaneous squamous. Next slide. So big thank you first and foremost to our patients, second also to our research staff, without which no clinical trials could ever occur, to co-investigators and the participating sites, to EMD Serrano, who provided avelumab and was a dedicated partner, and then to Dr. Gary Schwartz and the Alliance Experimental Therapeutics and Rare Tumors Group for really just support from the get-go, and a lot of patients. We enrolled this through the heart of COVID. And you can see by that pie chart there, our site at UPMC had 10, but mostly done with 5s and 4s and 3s and 1s, everybody working together to accrue a rare tumors trial in the advanced setting here for cutaneous squamous. Next slide. Funding is shown here. Next slide. And we were happy that concurrent with this presentation as an oral abstract at the head and neck oral abstract session at the meeting, we did get it published in JCO, so you can find that article online. Thank you for your attention. I think you might be on mute if you're speaking.
Sorry, thanks. I think my question touches on your nice pie graph where you show the participation. I think it's very notable, as you mentioned, that many sites enrolled, fewer than 3 patients. And it's, as you know, it is so hard for local investigators to keep these rare tumor studies open that are slow accruing. And how would you recommend that investigators advocate in their local cancer centers to keep these important studies open that have the potential to move the field forward?
Yeah, it's a really, really great question, and something that especially post-COVID, right, has faced even more itself. I mean, we tried to really talk to investigators and highlight or have them highlight to their centers that, it is a rare tumor type, right? And that's important for CCSG and core grants. And, what we tried to do here is that we included in authorship anybody that enrolled at least 2 patients. And, we did that on purpose because, look, I think one of the things that helps local investigators participate in rare tumor trials is if they have a chance at authorship, right? I think that's something that oftentimes comes up from the local PRC or otherwise, right, for investigators. So a lot of promoting, and then also trying to be meaningful there at the end as an example as to what can be the fruits for local investigators by participating in rare tumor type trials.
And maybe you can also discuss, what is the impact of Alliance and other cooperative groups in the space of rare tumor types? Why is NCI funding so important in this space?
Yeah, these are spaces where our pharmaceutical partners a lot of times will not do on their own, right? And so, the experimental therapeutics and rare tumors group, which now includes a sarcoma subgroup and a head and neck subgroup, right? It focuses on either rare tumor types or rare situations. And it is a niche in the cooperative group, and frankly, trials that only the cooperative group can do to be able to get the numbers to have a meaningful randomized trial with rare tumors, since again, most of the time pharma isn't doing it on their own.
Well, thank you. I appreciate your leadership in this study that is in its results. So thank you very much.
Thank you.
I think this brings us to the conclusion of our webinar. I thank you everybody for attending. If you could take a few minutes and use this QR code to give us some feedback on our session today to help us plan future sessions, not only for investigators, the NCTN community, but also for the public at large. We would all greatly appreciate it. And I would also like to take a moment to give some special thanks to not only our group chair, Dr. Eva Galanis, our panelists, Alliance scientific and administrative leaders, our sponsors at the National Cancer Institute, our other cooperative groups, our whole NCTN members in the infrastructure that support our clinical trials, the Alliance staff that tirelessly works behind the scenes that make everything that we do happen, our pharmaceutical and foundation collaborators and sponsors that help us, and most importantly, to our patients and the caregivers who bravely enroll in our clinical trials. And the collective efforts of everyone really are impactful in moving our field forward. And thank you very much, and we look forward to seeing you in the future.